My name is Emily Robson, and I use she, her pronouns. I am relatively new to the BRE Collaborative and Foundation of Healthcare Quality as the Transformation and Community Partnership Manager. I am an individual that today I have long brown hair, I'm wearing glasses, and I have a white sweater on. The background for mine is just blurred so you don't see into my kitchen. I wanted to highlight that I'm speaking from unceded land of the Duwamish tribe. We acknowledge the Native people, past, future, and present, who have cultivated the land within Washington state, their knowledge and practices that support the health of the people, animals, plants, land in our area. As we begin this presentation, I just wanted to highlight that all of you have been placed on mute upon entering the webinar. At the end of these presentations, we will have a portion for questions and answers. Please write your questions you may have for our presenters in the Q&A box that should be located at the bottom of your screen. The recording and slides to this presentation will be accessible after the meeting, so hope you'll be able to receive an email then with this information. We wanted to provide some information on the Foundation of Healthcare Quality. The foundation has 6 programs, which one of them is the BRE Collaborative. Our other remaining programs that you can receive more information about on our website are the Care Outcomes Assessment Program, Smooth Transitions, and Washington Patient Safety Coalition. For some background on the BRE Collaborative, it was created in 2011 by the legislature to bring together members from different areas of the healthcare sector, which you can see on your screen, to address key health topics that impact Washingtonians by being a place for convening and collaboration. This past year, we were able to work on opioid prescribing in older adults, outpatient infection control, which we're very excited to talk to you all about today. We have hepatitis C and pediatric asthma. The information you see on the screen currently reviews the roadmap to health ecosystem improvement that the BRE Collaborative supports. We work with a lot of different individuals from different sectors to create, which we have now done, about 40 plus recommendations to support our mission of improved healthcare quality, outcomes, affordability, and equity. On this screen, you can just see a few of our highlights of some of the topics we've been able to accomplish. And this upcoming year in 2023, we plan to focus on diabetes care, maternal mental health, and difficult to discharge patients. If you have interest of joining any of those work groups, we'll provide some contact for Nick Locke in the chat below at the end of this presentation. But today, we have the immense honor and excitement to hear from Dr. Mark Haugen and Lisa Hannah, my apologies, on how these recommendations for outpatient infection control can be utilized in your own settings. So I'll pass it over to Dr. Haugen.
Thank you very much, Emily. Can everybody hear me okay? So I just want to give you a little bit of background of who I am, since this is about infection outpatient control. And I graduated med school from Creighton University in Omaha, Nebraska, went into family medicine and did my residency in Reading, Pennsylvania. And now, of course, in Walla, Washington at the Walla Clinic. I also practiced 5 years in a system in the Southern Ohio before I came here. And I've been here since 2009. I became a medical director of a nursing home in 2009 also. And so really my only experience with infection control is definitely in the outpatient setting and then in a nursing facility. I'm not an infectious disease trained physician by any means on following regulatory guidelines that I've been exposed to in my own career. I did do 5 years of rounding in the hospital setting in Ohio, and then hospitalists have overtaken that pretty much, which is okay in my view, since they do it routinely. I think my interest really arose during COVID. I was part of an outbreak in a nursing home setting. We definitely had majority of my building infected. We lost people due to the disease. It was 3 weeks, a very difficult time, all a month before vaccines were released. So we didn't have a lot of capabilities at that time. Meaning we had a lot of potential things you could do, but really kind of just got to watch that disease run through my nursing home and staff. And so I think and then working in my clinical setting at the Walla Clinic was exposed to just in Eastern Washington, we had to balance where we have a little more skepticism in reality. And it's difficult to balance sometimes patient expectations. And in all honesty, I mean, the mask mandate really meant a lot for us to be able to defer some of these, what seem like logical infectious control modalities uh, uh, to be really implemented with probably less animosity, I would say, in some cases. And that may seem like kind of silly in some ways, but it's kind of the reality that we face in this part of the state, I guess, to balance that with our patient clientele and their own expectations and beliefs. So that's a little bit of my background, kind of where I was standing about a year and a half ago, and that's what brought this topic to even become a topic for the BRE to review. Next slide. And it really came from May of 2021, when now that, we had survived basically the first two waves of COVID, well, three waves technically of 2020, early 2021. Things seemed to be settling down. People were talking about stopping the mandate by, by that time, President Biden was talking about everything would be better by July 4th. And so, in my mind, as I sat listening to the BRE topic discussion, it was like, okay, when the COVID mandates end, what does that mean for outpatient infection control? Are we going to go back to the CDC's outpatient infectious control guidelines, which are pretty much cough etiquette? Is that really what we've learned from COVID? I mean, are masks making more sense than cough etiquette? Or what's the best way to move forward? Having experienced what we experienced the last year and a half with COVID at that moment. And so that's really the three questions I was asking pretty much right there. At that point, COVID, the Washington state had issued the state of emergency. It started in February 29, 2020. At that point, we had gone through a shelter in place. We had a mask mandate. We had vaccination requirements. All this kind of evolved, of course, over the next year and a half by the time I was contemplating those questions. And then, again, at that point, in May of 2021, it's like, how are we going to move forward? And then, of course, Delta hit, which just pushed everything out really until this fall, when finally we've had some exemption, or finally the state emergency ended, except, of course, where's healthcare in this? And I would say at that point, my idea of the document was going to be more of a functional thing that would move forward to say broader than just COVID. It was really to impact, how do you handle any infectious disease control in the outpatient setting? So really the view was always going to be, how do we address anything moving forward, whether it's COVID. I was also a medical director in the around 2014 to 18, when we had the Ebola concern, and so wrote policy for how we direct patients during that time. And so I'd lived through kind of some of the policy prep for that. And so again, how do you make a document that can help outpatient settings move forward in a broad swipe to cover multiple entities? Next slide. So, the CDC guidelines, I mean, the example I went to kind of just say what exists. They have a comprehensive document. It covers, infectious control. It covers surveillance and reporting. It covers hand washing, PPE, cleansing, disinfection, sterilization. But then respiratory hygiene and cough etiquette, to me, was kind of, when I think of rounding in the hospital, and we isolate patients because they have potential tuberculosis, or they have, MRSA or whatever, or in my nursing home, when we would isolate people, we always had certain amount of PPE requirements. And so is really respiratory hygiene and just cough etiquette enough in the outpatient setting? And that was kind of my greatest concern in looking at this and moving forward on what would be the best thing forward. Next slide. Just to give you a background of the Walla Clinic, for those that aren't familiar, kind of also gives you an idea where my world is. Most of my practice has been in communities that are more rural, so 30,000 people. So that's really the world I've lived in. So this is a multi-specialty group. We have 31 physicians. We have multiple specialties in primary care and from orthopedics to radiology to endocrinology, allergy. We're physician owned. We're one of two that I'm aware of multi-specialty groups that are still around. Vancouver clinics, the other one, a lot have been obtained or have partnerships these days. And so we live in that world, which has become more difficult. We have plenty of patient visits throughout the year. We have 3 satellite clinics with 5 main campus buildings. And then we do the support here for us. We don't have a lot of top administrative people to really be the support. I mean, those 3 positions I list there were pretty much what we had to kind of coordinate our care during COVID. And so, it was a lot of work and a lot of physician involvement, I would say, is what we had to do. And what I'm going to roll through next is kind of what my clinic did initially in COVID, just to kind of, again, give some background to what my experience was, and then kind of how that rolled into that experience into the document, and then maybe just how that can help people use the document to implement, and then other resources that Lisa will talk about after me. So, things we had to do, we had to figure out when the shelter in place got put into, and we were all going to shut down from April to May 16th or 17th, whatever that date was, what constituted a necessary visit. And everybody approached this different, what was really necessary healthcare at that point. And that was really what my department and multiple departments within the clinic had to evaluate what we were going to see. And so we didn't feel visits were necessary visits at that point. We only saw acute, really non-respiratory on call days for docs in the office to limit office exposure, trying to avoid people getting ill. Even chronically ill stuff got pushed off for those kind of 6 weeks to some degree, or we did telehealth visits to kind of maintain contact with patients. I did a lot of phone visits in April that year, just to, again, build some continuous continuity, letting patients know, hey, we didn't abandon you, we're still here. But the care is going to be a little different right now until we kind of get a figure out what's going to happen with this illness. We created telehealth. We didn't have really a platform. We had to use another platform, and in order to do that, we separated out acute respiratory and because we had limited PPE. And so at that point, we created a cold and flu clinic. It was in a separate building that we weren't actually using, but we owned, and it included lab testing there in order to completely isolate what the potential disease would be, since we just didn't know where it was going to go. We adjusted all of our schedules. We only have one entrance and exit in our buildings because we're squished between 2 other buildings. And so we had to watch our flow. And then, at that point, contaminated room meant you were out of commission for over an hour. And so part of that was just how do we flow through. And so we stagnated, or I guess we just alternated the times in different pods for when appointments would be. We reduced our capacity. We had multiple different capacities of schedules that we could implement at any time, varying what what we felt the office flow should be based on the community burden of illness. It was kind of how we did. We rearranged, the seats in the waiting room to be paired up and then distance from each other. So you could be with a visitor or with your one companion, and then you were a certain distance from someone else. We got rid of a lot of, I think our magazines were all gone, different things that we didn't want to have to disinfect, or, that would be hard to disinfect went away, determine what was important. And then as things have progressed since, we just allowed non-COVID patients back in. And then our walk-in burden was high, and they wanted us to start seeing more of our acute patients. And so then we started putting acute patients before lunch and at the end of the day. And now we pretty much have sufficient PPE. We're quick to get people in. We have them register prior to their visits, and different other protocols that have made it easier to manage exposure and make, and then we still have the mask mandate, so people are at least masking for the most part. Next slide. So, what's the best way to move forward is kind of really the question. And so this is really where, I proposed this idea. Let's review the outpatient infectious control. Is there better things to include? Are there important things to include, not only from a health system, but other maybe audiences? And so this is where the collaboration work group was proposed for this as a topic of discussion in 21, and then with the group to be meeting in 22. So we felt it allowed an opportunity for all parties' interests and opinions to be discussed. We allowed a format. We felt it would allow a format to review the past, current, and developing guidelines. We just allowed production of a document to consolidate maybe some recommendations, also hyperlink to maybe some of the current resources. And so that's really what we were hoping for there. That was the goal. Next slide. This is the list of the people that participated in the work group. I chaired it, and then we had some local health department individuals. We had some business individuals. We had the state level health department. We had a physician that was initially a hospitalist and then became the head of an insurer, or medical director of an insurer. So we kind of had and then we had an ASC nurse. So we had kind of a nice mix of individuals that had different exposure to what kind of infectious control concerns that they would have. So next slide. The audiences that we were targeting, initially, that was the biggest discussion, was kind of the focal areas, which you'll see in the next slide, and then the audience and what do we want to really get out of this document. And so we felt the outpatient health systems, and then as we got into the document, realized there's two sides to that. There's the providers and staff, and then there's the administrative side. And so we segmented that out, and then we addressed employers. Again, on that front, we were really just making generalized guidelines because we knew different businesses would do different things. And so again, didn't want to pigeonhole to anything specifically. And then address plans, public health systems, and patients. I do see, I want to step back. I saw there's a question that came out from a person in the audience, and about upgraded ventilation and filtration. And we did do that in pediatrics. And so because they were the first group to start seeing acute individuals. And we also did that in the walk-in when we were doing the cold and flu clinic. We moved it back to our original campus and split it into two segments. And so we did address that issue. And really, in my office, we've designated a couple rooms as the primary places to look at acute individuals. The focus areas we focused on were 6. Some of this is consistent with other BRIE topics, and so being kind of consistent to where the BRIE analyzes different topics. We looked at the preventative measures and kind of developed some goals within that, and I'll show you some segments of the document itself that kind of address what those goals were. But, what can we do as far as using PPE? How do we prevent vaccines? The proper precautions to monitoring surveillance. So how do we coordinate with local Department of Health and monitoring the disease? How do we inform patients? All that. Here locally in Walla, we actually had a weekly community meeting, which I was especially part of during the my nursing home director days, in which we met once a week, and we had EMS to hospital to all nursing facilities to outpatient facilities, and just had a common kind of like what's happening in the community right now and what do you guys need. We had the county Department of Health supplier there, so if people needed different PPE or different things like that, everybody could kind of put in their input. Some people would share resources in that case. So it was very great community effort on that front. Minimizing exposure. So how can we prevent? What kind of things can we do to prevent? We, on the outpatient setting, we actually created a workflow example, whether it was acutely ill, suspected disease to, so high risk essentially, and then low risk would be someone that's just chronically ill. And we treat that as a normal patient in our office. So we try to even outline how an office could maybe think about managing high risk to low risk patients in a situation of even an epidemic versus just everyday considerations of how, hey, if I have a patient coming in for acute illness and they've got a cough, if you take away the mask mandates, you could still wear a mask, obviously not to expose, maybe better than cough etiquette kind of questions answered. Environment of care, again, just putting some emphasis back on how do we disinfect and how do we pay attention to that. Same thing with sterilization, high level disinfection. These are things that, should be happening every day, but sometimes when you get distracted by other responsibilities such as COVID or an epidemic, then you get concerned about these things kind of slide to the wayside, and hey, is the dirty getting too close to the clean and stuff like that. We need to make sure we're keeping up on all the other aspects of proper infection control. And then the last is just community spread. How do we partner with other people, patients, communities? I did some talks in the community, different things. I made some videos on COVID and vaccines and presented to some schools here locally, did different things like that. That was my community outreach. What does the document do? So here's some examples. I just took different pieces out of the document to kind of give some idea. I didn't obviously want to just talk through the document. And so this gives you an idea how it's structured. So this is outpatient health system. So for example, for administration, prevention, you want to initiate appropriate standard contract droplet airborne precautions. You want to educate staff. And then on the provider side, it's like you want to inform patients about the risk of an infection, educate them. We talked about vaccinations and how to address hesitancy, things of that nature. Next slide, please. And then on the employer side, to give an example, minimizing exposure, whether you have a patient that or employee that maybe has been exposed, and are as high risk, maybe they need to do telework. Is there alternatives to their work? So that's one example. Insurers, again, on the prevention side, covering at home. We're going to probably have more home testing in the future. So covering those things, providing incentives for vaccination, covering the cost of vaccination, things that seem pretty obvious to do, but sometimes just needs to be stated. Public health, just really helpful in monitoring, creating dashboards. I saw some really great dashboards for COVID across the country. But is that going to be the same for other diseases, and how well that's communicated to us in practice? And then patients, community spread, just how can we educate our patients and maintain distance and follow some guidelines? So that's kind of how the document's structured and how we made our recommendations in the document. The importance to me of this document and how it can be helpful is, it allows people maybe to outline how they might self-assess their own infectious control measures and practices. It could outline ways to prepare for and plan for future outbreaks, maybe be an outline of how to have that discussion, or provide resources that you can refer to of how others have done it. I think it's important right now. Obviously, we have this, everybody likes to say triple threat. These, we've got a lot of respiratory illnesses going on right now. And so, here we are. So it's definitely right at the moment. The timing is perfect. And then it can outline how to establish some partnerships with people in the community and coordinate with these entities to, provide resources and support. And then how do you move forward in the new normal? And that's really, part of what we're really shooting for, is to make a document that wouldn't, it might have to be updated, but at the same time it can provide us kind of, I guess, a guidance in all situations, even moving forward. So, and I'll look here. I think there's one question maybe to look at.
We can hold off on the question
Okay.
until the end. We can let our
Sure.
next speaker go. Thank you so much, Dr. Haugen, and we will have Lisa Hannon from the Department of Health speak now.
Hi, everybody. I'm Lisa Hanna, and I'm very happy to be here today. I am an infection prevention supervisor with the Washington State Department of Health. I am within the Office of Communicable Disease and Epidemiology and the Healthcare Associated Infections group. So just wanted to just quickly discuss how facilities can use this document in their outpatient setting. So one of the great things about the document is it has links to the current evidence-based guidance. So, sometimes it's hard to find that information in your search down the internet, and wanting to make sure you have the most current and up-to-date information. So as you work through the document, you'll see links there that you can click on. It will take you right to that. We really wanted to be able to offer recommendations for the outpatient facilities on infection prevention, but it wasn't meant to add more of a regulatory burden. So this is suggested guidance, but also it does link into, there is some regulations for this. I was hoping that as you use this document and go through and kind of think about the processes that you already have in place, that you can identify maybe some focus areas to look at. And that can help guide your quality improvement activities. So by working through, you can do a self-assessment, you can look for some of those gaps, and you can kind of outline next steps. What are we going to do to prepare for this? Do we have enough PPE available? Are we educating our staff? And how are we going to communicate this with our community or our patients also, to make sure that they have the resources that they need and are comfortable with the guidance that we're giving them? And then really wanted to demonstrate the need and importance of having coordinated efforts. There's a lot going on right now, as we're seeing with our respiratory illnesses. There is, a current Ebola virus disease outbreak. there's a lot going on. We have a very mobile population that can jump on a plane and go to another area and come back home. So making sure that we have the resources where our staff feel comfortable and could look and find that current information. And then, of course, always recommend that you have a relationship or partnership with your local public health also. Next slide, please. So one of the things that while working on this document, I just wanted to share that the Department of Health and our HAI team, we do offer ICAR consultations. It's an infection control assessment and response. These are non-regulatory voluntary visits, usually takes 1 hour to 2 hours. And we use a standardized checklist to kind of go through the infection prevention practices, and really it's meant to do a quick evaluation of your policies and procedures, but also to kind of do a visit through your clinic, walk through. It's another set of eyes, and we look at things like safe injection practices and PPE availability, cleaning and disinfecting, kind of those core infection prevention practices. And this is collaborated between your clinic and local state public health. And I just added a map to show the different areas of Washington. So we have two, we call them teams, Team A and Team B, of infection preventionists and epidemiologists. So some are nurses, some have a background in epidemiology, but we've split the area in blue is Team A, so more of the Puget Sound area. And for each of the different colors on the map, we have an infection preventionist assigned to that area. So it's a person that is a regular contact, and if there are questions, people know who they can reach out to. And then you'll see the shades of green, that is Team B, and that is the group that I supervise. And so you can see we're a little bit more spread out in Washington on Team B, but again, same goal is that you have one person in each of your LHAs that you can reach out to. Next slide, please. So the ICAR tool is similar to this document. Really, it's meant to be educational and to help do a self-assessment. We are non-regulatory, and again, it is voluntary, but it can point out gaps maybe of areas that education might be needed with your staff, and something that we are happy to help with. And the document is also very structured. Of course, you can choose to use certain areas, but it's consistent. So we can have a consistent evaluation from site to site. Of course, it is personalized, and we really enjoy going on site. So we can do direct observations, and but again, we're very collaborative. We want to make sure that any visits that we do works for our facilities and our providers, and it's never meant to be a burden. Next slide. And just wanted to go back for the educational part. We really work on having a supportive relationship with the facilities that we work with, and want to be able to make sure that we can provide assistance. If there is an area that someone would like more information, that we can share that information, that we can try to validate any practices that there's questions about, and then of course the relationship continues. It's not just a one visit and we're gone. We are there for phone calls. Throughout the pandemic, we've been focusing on mostly long-term care facilities and acute care hospitals, but we do have a history of working with outpatient and ambulatory clinics. And so it's been nice in the last few months to be able to go back and do more outreach. So just again, our goal is for outpatient setting, you're going to get tailored resources, tools, and training. You're going to have an ongoing consultation with infection preventionists from the state, and really wanting a sustainable partnership for ongoing improvement. And then also want to make sure that we are able to connect different teams within Department of Health with the facilities. So we have occupational health nurses, industrial hygienists, epidemiologists, and then of course, we work very closely with the immunization team at Department of Health. Next slide. And just again, just stress that it's really personalized. We want to make sure that our visits and our consultations really are going to assess your clinic. We understand that every clinic is different, and that you guys have your own priorities and concerns also. So definitely this is facility driven, and we are happy to hear your suggestions and input also. And yeah, so just really like to just be able to do a walkthrough. And sometimes it's nice to have an extra set of eyes. You know, we get used to seeing the same thing every day. And sometimes someone else coming in might see something a little different, make some suggestions. Next slide, please. And then I just added some links. And so if there's any questions, feel free to reach out to myself, Lisa Hanna. And then we also have other mailboxes that are monitored Monday through Friday, and in case there are questions that come up. And just wanted to also share that we did, and it's addressed in the document too, just kind of with the masking mandate and the respirator recommendations, that your staff should be fit tested with the N95 or a respirator. And we do have resources to help with that at Department of Health. So if there is any questions, feel free to reach out, and we are happy to help with that and point out some resources. Next slide. That's it. Thank you.
Thank you so much, Lisa, and thank you, Mark. I think now we would like to invite both of you back so that we can go over a brief question and answer. We do have some questions prepared that we can run through, but if you are in the audience and you have any questions after both of those presentations, please feel free to put them in the Q&A. Before we begin, though, my name is Nick Locke. I use he, him pronouns, and I'm the Director of Research and Best Practice at the Foundation. And it was my pleasure to help facilitate this work group. I like to say that I am not the expert, but I like to bring together the experts like Lisa and Mark and be able to learn from their experience. So to start, I'd like to just offer a fun question that we prepared, which is, after supporting the creation of this recommendation, I know both of you were involved with our work groups for about 8 months. What aspect of the recommendations are you most proud of or most excited about?
You want to go first? Or you want me to? I mean, I think for me, I mean, obviously the applicability of it is probably what I'm most excited about. And for the clinical side is what I know. And so I think that's where I'm most comfortable. So that's where, you know, I think there's just practical stuff here. I think the other part that's interesting is, you know, it expanded my thought process into those other audiences. And so I think it can maybe help someone really think, how do we do this as a community? So, and that's always exciting to me. I think medicine's more exciting when you can work as a team.
So, and what I am really excited about is just the ability for clinics to think about the processes that are already in place and to build off of what they have. And I am a big proponent of being prepared. So making sure we have our policies and procedures in place, and that we have our supply chain for our PPE, and we know who our partners are ahead of time before there is a crisis. So I'm really excited about that aspect.
Yeah, it's great to hear the highlights include collaboration as well as being prepared. And I know many of us feel like we're nearing the end of our current pandemic, but we never know what's in store for us next year or how case counts will change over the holidays and things like that. I do see we have one other audience question. Andrea asks, the use of PPE increases our carbon footprint. Has there been a risk-benefit analysis on increasing PPE use as compared to our carbon footprint? I can start by saying that I don't think we directly addressed the environmental impacts of PPE in the recommendation itself, but I would be interested, Lisa or Mark, if you have any comments there.
I would bet it's hard to, I mean, I think we're still recovering in the scientific world to figure out what we did right and what we did wrong. And then to expand it to the environmental impact. I mean, I can tell you, working in a nursing home during an outbreak or just in general, and the amount of testing and the amount of PPE, yes, our trash went up a lot. I mean, I know the director was telling me, just how much trash we were throwing. So I think that's very unfortunate. I think it needs to be one of those components, but I think that's a bigger, I mean, that was something that was brought up this year at the BRE collaboration as a topic, was looking at the, the impact of some of our, just the supply chains and what we go through in healthcare as far as how green is healthcare. And so I think, I think people are starting to look at that more and more. And so I would imagine it's, as people show interest in those things, it's going to, those risk benefits will be analyzed more and more. It just takes, people to be interested in it, I think, and question it and say, hey, can we do this better? And how do we do it better? Is there ways to, use PPE in a different way or use it more appropriately so that we don't have as big a green or, big of carbon footprint? I don't know, Lisa, you have thoughts?
I do. So I don't know of any studies that have been released really looking at this, but I do know that there are some alternatives out there, or some places have looked at the reusable respirators that can be cleaned and disinfected. There are options for launderable isolation gowns. And again, there's the pros and the cons. There's reusable gowns that can be cleaned, but then you also have to have the ability to do the laundry and to keep up with it. So I do know that there has been some, at least within Washington, some facilities have been looking into changing some of their practices, but we're not going to get away from, PPE has always been required for certain things. So we're still going to have gloves and gowns and masks, but making sure that we're using them appropriately, I think, is important. And then also knowing the proper disposal. Early on in the pandemic, we were seeing a lot of facilities that were putting all of their trash into red biohazard bags, which wasn't necessary, and really increased the cost for disposal also. So making sure that we're educated and knowledge on the proper disposal is also important.
Yeah, thank you. And I'd like to highlight, I know, Mark, you mentioned that the BRE Collaborative, when we were choosing our 2023 topics, we considered climate change and environmental impacts as a topic. That is not currently a topic that we are looking at alone, but we do want to incorporate that lens into our topics moving forward. For example, with one of our other work groups on pediatric asthma, we've been discussing the use of dry powder inhalers versus aerosolizing inhalers. So I hope that we'll be able to keep having that conversation on healthcare's carbon footprint in the future. One of our other questions specific to infection control is, what have you two noticed or have you seen in your practice as the most significant barrier to implementing either these guidelines or other best practices for outpatient infection control? And how might someone, or how have your organizations gone about addressing those barriers?
I mean, it's a great question. Unfortunately, I think at this point in the game, the problem is just fatigue, is I think the biggest barrier. So I think people are just tired. You know, and especially like, I mean, I'm the president of the clinic right now. And, you know, I remember last week we had, you know, our business office people are like, do we really need to wear masks? We don't see people very much, you know, if at all, you know, so you're getting some of this, I think, pushback now where, okay, and I think that's where I think moving forward again, there is, you know, pretty good, CDC came up with a pretty good mask kind of guideline, and so when can we get to that point in the healthcare facility, in the outpatient facility, and I think that's, you know, I think we'll keep getting pushback as long as, you know, and the other problem is, I mean, we're not that far from Idaho, and you know, there, you know, some states don't do anything. So I mean, I think that's part of it too, is when you get some variety in that, where the people are seeing, hey, different people do things different ways. That doesn't make it easier either. The best way is, I mean, support, kind of trying to just reinforce, hey, you know, the reasons why we're doing certain things, and trying to, again, make it probably more about the patient in at least in the healthcare setting, that we're just trying to take care of patients as best as we can to keep them as healthy as we can. It's probably the best thing we can inspire people to do.
I think still the availability of some PPE is hard for some settings, and also just the staff turnover. And I don't know if you guys see it as much in the outpatient settings, but I know in acute care and long-term care, there's been a lot of turnover. And so it seems like it's a constant re-education as new people come in. And so that has been a challenge, I think, sometimes. And that's an area where, you know, in the document, we're taking a look at sterile processing and high-level disinfection and cleaning and disinfection. You know, we've been so focused on other things that maybe new staff have come in and they didn't get as much of an orientation on some of these as, you know, we would have, say, 3 years ago. And so sometimes it's just you don't know what you don't know. And so being able to really take a good look at the current practices and not trying to identify gaps has been very, I think, helpful.
Yeah, thank you. I think I noticed in both of those comments, there's an element about reducing burnout, reducing turnover, trying to address some of our shortage in both maybe physical resources like PPE, as well as human resources. I think we have a follow-up question in the chat sort of about how to overcome some of these barriers. Christopher asks, I'm curious if as an organization, you have been able to incentivize practices to utilize infection control audits. So things such as certificates for practices in order to incentivize having site visits. So I'm not sure, this might be a question, Lisa, that you may be able to answer.
Yeah, I can. So currently we do have like a certificate of participation that after the visit that we can send out. So there is a certificate, and then there's also a window cling that it has the year and participation, but just it's something that that was feedback that we had received quite a while ago, years pre-COVID, that some facilities wanted something that they could show, like that they had participated and used it to kind of help to show that they were putting in that extra time and effort. So yes, we have those options, and in the past we've been able to help with some educational pieces to help incentivize clinics and to participate. But currently we have the certificates and the window clings.
And so do those come from the Department of Health if someone participates in the ICAR? Perfect.
Yeah, they get sent out. I think it's like maybe a few weeks after the visit. I'm not really sure what the turnaround time is, but and then for each year, there is a different, you know, just it's slightly different. So is there any other questions about that?
I'm not currently seeing any. Please feel free to continue to enter some though. In the meantime, I do have one other pre-prepared question. So for those who are looking to implement outpatient infection control measures in their setting, how might you measure either process or outcomes for implementation of infection control procedures?
I mean, to me, that's tracking. I mean, you just have to be able to track your illness levels. And I mean, it's like any other metric that you put into any clinical setting. I mean, you have to decide what you want to make as a goal, what you're implementing, and then and I think the third part is always, how do I actually measure it and track that? And so anytime you implement some kind of change process, I mean, an outpatient infection control can be a little bit difficult. I mean, because, a lot of times if I have someone acutely come in, I may not actually know what really, they just don't show up again, right, in reality, or I might not find out if, we probably took for granted in the outpatient setting most of the time, if someone was sitting in our waiting room, we probably don't really track who gets sick within our waiting room because they're in our waiting room until usually this time of year. I'll hear like, yeah, I was in your office and then I got a cold, 2 days later, and I've heard that already this year a couple of times. So, I mean, that's the problem. I mean, unless you find a way to report that, you're probably not going to be able to track some of the controls. So I think some of it is probably depending on people at the Department of Health and other, people that write the guidelines to what their experience is in true infection control, because they're probably looking at these. So in my clinical setting, I'm probably not going to be tracking that closely. I'm just going to rely on where the guidelines are, what best practices are, and then how do I implement those, more than trying to figure that out, and that's in all honesty.
Yeah, I appreciate the honesty, Mark.
Yeah, and I think that it's also, looking at different things. Well, number one, you need to know your baseline. So whatever process you're going to work on, making sure that you have a good assessment of the current situation. And then, setting a clear and realistic goal to work towards, and then being willing to reevaluate that. And, this is an ongoing process. So I just encourage, having a group. I know it might, in some settings, it might be a very small group, but just really being able to collaborate and talk about what you're seeing, and, not being afraid to start small and then expand as needed.
Yeah, thank you, Lisa. I appreciate what you're saying there about this being an ongoing process. We know no matter what happens with COVID, we are going to be dealing with infection control in the outpatient setting, from diseases that we are expecting, like RSV and flu, and diseases that we might not expect in the future. But thank you both for joining us today to talk about our outpatient infection control guidelines. I believe Emily has entered into the chat a link where you can find the full report on our website. We will also be sending out a recording of this webinar within a week of this event. So if you want to either share this webinar for training purposes or to others in your networks, please feel free to do so. But thank you to everyone for attending. I just want to highlight a few future BRIE events that are coming up. We will be hosting 2 more webinars on recommendations in early 2023. We have a planned event related to our hepatitis C virus elimination recommendation that will be held on January 18th, 2023. So much like this one. And then we will be planning a pediatric asthma webinar once that report is completed in early 2023. Additionally, if you are interested in participating in any of our work groups, whether that's our maternal mental health work group, difficult to discharge, or diabetes care, please feel free to reach out to me. My email as well is in the chat, nlock@qualityhealth.org. But thank you all for attending today, and I hope you have a great rest of your holiday season.
Thank you very much.
Thanks, Mark.